cell itself that basically degenerates. So for the instance of Duchenne's muscular dystrophy, the gene codes for something called dystrophin. The only reason that's important is that dystrophin is functionally like 2x4s in a house. So if you tried to build a house without 2x4s, eventually that would all just come crashing down, and it would get replaced with whatever you kind of fit in the gap to kind of hold it together. And so that's what happens in Duchenne's muscular dystrophy, is that the cytoskeleton, the dystrophin makes the cytoskeleton of the muscle cell. It's got an abnormality, so that cytoskeleton collapses, and the body fills that in with fibrotic tissue. So that's what's going on with these type of muscular dystrophy. So not only is the muscle cell degenerating, it's then getting replaced with non-muscle cell. And so the most severe type is going to be Duchenne's muscular dystrophy, so be aware of that one. That's the one that we're going to kind of fixate on. But Becker's is the second type, a little bit like Duchenne's light. Just thinking about that. The thing that makes it easily testable is that it is, number one, X-linked, so it's only going to affect boys. So you're not really going to see this in little girls. So if you get a clinical presentation of this in a little girl, they're trying to confuse you with something else. It is that dystrophin gene. And the reason that they're asymptomatic as infants, remember, what does a baby do when they come out of the womb? They're a little cockroach, not much. So they're just kind of laying there, right? So they're not using these muscle cells to the same extent that we do as we start becoming a fully functioning human. So asymptomatic, and then as they start doing their gross motor milestones, which is why we pulled that all the way from block 1. So as they're learning to crawl, then walk, then run, they're trying to do all of those things, those gross motor milestones, they have a lot of problems with that. And so one of the first signs you'll see, and we'll talk about that, but is they're toe walkers, obligatory toe walkers, because they don't have all of that calf muscle. By the time they're toddlers and into those school-aged years, it is very, very evident that something isn't quite right. So we'll take a look at that. So one of the things you'll see is that if you have a patient, they will have these very, very large calves. So it's a little bit hard to appreciate without the rest of the child there, but you have these very, very large calf muscles. So a lot of people will think, oh, the muscle cell itself is bigger. Like, no. It is pseudo-hypertrophy because the cells themselves have degraded and the body has filled this in with a lot of fibrotic tissue. So the calves themselves look really big, but it is actually not muscle cell at all. So it's a pseudo-hypertrophy of the calves. And then because the muscle really isn't there, it really isn't strong, they're trying to walk on their toes with all the rest of the compensatory muscles. That'll work for a little while. It's actually next one. That'll work for a little while, and then they'll start to be like, that's not working, and so then they'll get more of a wider gait. So they're kind of going side to side to kind of use some more compensatory muscles. The next thing you'll start seeing is when the legs are starting to get weak, they're having to use their upper body. So if you've ever watched an 80-year-old man or a grandparent get up off the floor, you ever watched that? Like they're like using their whole body and they're like crawling up their body to be able to stand upright. You don't expect that in a 3-year-old. You expect a 3-year-old to look like they are like Gumby, and they're just like, I hit the floor and I keep bouncing off. And that's what you expect in a small toddler. You don't expect them to look like they're an 80-year-old walking up their body. So when you are watching that little boy at the bottom, that's what the Gower maneuver or the Gower sign is when they're walking up their own body to be able to stand upright. They'll end up with upper body weakness. It'll continue to ascend as you start continuing to have that degradation and the fibrotic replacement. Eventually, these children will be wheelchair bound, and you start seeing that it ends up affecting the diaphragm, all the musculature of the face, the ability to swallow, and eventually they will succumb usually in their later teen years. So a very, very sad disease, but something that you can help mitigate the earlier you pick it up. This does not mean that every little boy who walks on his toes has muscular dystrophy. Please hear me when I say that. But it means that that's a little kid that you need to make sure that their gross motor milestones are on track and they are continuing to progress. What are your labs? Well, I certainly want to make sure all my cell lines are normal, so I want to make sure my CBC is okay. I want to make sure that my electrolytes are okay, that my protein's okay, that my liver and kidneys are functioning okay. So my kind of a once over with a CBC CMP. And then my muscle enzymes. I would expect my CK, which is what? Creatine kinase, yep, to be through the roof because my muscle cells are constantly falling apart and degrading. So that's why I expect that to see it through the roof. You're checking to see if there's anything else neurologic going on, so they'll end up having a lumbar puncture. And eventually, your diagnostic clarity will come from when they take a muscle biopsy and they actually look at the DNA themselves to say what is going on with the muscle tissue and then what is going on with that dystrophin gene. Neurology will do that, and neurology will eventually manage that. Okay, so then we get into a whole realm of neurocutaneous. So what two systems do you think go together for neurocutaneous? Skin and brain, right? Yes. And you're like, why does skin and brain go together? Well, it all goes back to embryology. So all of these things are derived from the same embryologic structure, your ectoderm. And so your ectoderm is going to make it so that eventually your neurologic system forms from that, and also all of the things that make your dermatologic system. So that makes your skin, your hair, your nails, your teeth. So when you're thinking, so you have seizures and some weird teeth things? Yeah, because it's all ectoderm tissue, all that same embryologic structure. Things that we're going to look at in particular and do a deep dive on. Number one is neurofibromatosis. The word association there, we're going to deep dive again, but the word association, NF1 with cafe au lait macules, talk about that. Tuberous sclerosis, the boards love that one. I think I've seen it twice, and they love it. Adenomyosedation, we'll talk about what that is and why. And then Sturge-Weber with a port wine stain. So if you're word associating, learning those quick ones, that's where we're going to go. We'll talk about them in detail. So, neurofibromatosis, when I was going through, we all called it von Recklinghausen's disease. And then we started to get away from that, so just if you see it, if the board ever puts that up or someone says, I have von Recklinghausen disease, that's what they're talking about. But it's NF1 or neurofibromatosis 1. If you're thinking autosomal dominant, how many parents have this then? Yeah, one or two, but one parent has the disease. Okay, so autosomal dominant, meaning it's from not the sex, so it's not X or Y linked, it is in the rest of the genome, and one of your parents has this. It's on chromosome 17, and it is neurofibromin. And the reason that it's interesting that it's neurofibromin is that this is a tumor regulator gene. And so there should be something that says stop, we're going to make neurofibromin, and then we're going to stop, and that stop mechanism doesn't work for these patients. So it just continues to make neurofibromin over and over and over. So the fact that it's making neurofibromin is not the problem. It's that there's no stop mechanism. Okay. They'll make Schwann cells, and really eventually, again, since it's not, neurofibromin is not the problem, it's how much it's making and where it's making it. So eventually this becomes partially a cosmetic issue, thinking about this. For all of these, I don't need you guys to spend your time being like, which chromosome is this on? This is just in general to make you realize it's another reminder, it's autosomal dominant and and where it's coming from, what this is. So, but I'm not going to say neurofibromatosis is from what chromosome. I'm not going to do that, but it can be helpful as a context. So if you're looking at a patient who has neurofibromatosis, you're looking at cafe au lait spots. What is functionally a cafe au lait macule? What do we call it? What does the lay people call it? A birthmark. Yeah. So how many people have a birthmark in here? Yeah, look, like half the people, right? Cafe au lait happen all the time. Do you have more than 6 that are more than half a centimeter in size? Most people don't, right? So a lot of people will have a cafe au lait or 2. Most people don't have really large ones or lots of them. So cafe au lait spots, almost all your patients with NF1 are going to have this. What I need you to do is go home tonight, or when you're at the gym tonight, and I need you to look at your armpits and in your groin. Probably most people don't have freckles there. Even if you have a lot of freckles, Most people will not have them in their armpits and in their front. So go home, check your spouse, check your boyfriend's girlfriends, check yourself, check your kids, because most people don't have this. I'm gonna ask you about this next time I lecture. Did you check for this, right? Just a story, I was at the gym lifting with one of my friends at a previous base, and I was like, she has axillary freckling. And it popped into my head. And I saw her kid, I was her kid's pediatrician on base, and the kid has an NF1 mimicker. Right? So eventually that led to a diagnosis because I saw axillary freckling. Right? So these are uncommon signs that you can start picking up to say, huh, that's not normal. So check your armpits tonight. Because that continues to make neurofibromin, you have this cutaneous neurofibromas that can be really innumerable. There's tons of them all over the body. And then something that I don't care about as much, but y'all will, is you see them more with age. You see those benign hamartomas, or those benign tumors made up of Schwann cells, neurofibromas in the eyes, wish nodules, as they get older. So down here you're seeing all these neurofibromas. You're seeing this kiddo with cafe au lait macules, and then you see some axillary freckling. So those are some of those cardinal symptoms that you see with this. So what about the diagnostic criteria? Like, this sounds genetic in nature, like, are you really, as a PA, am I really as a pediatrician going to make this diagnosis? Yes, we are. Because the criteria says I need two of these things. I need to have multiple cafe au lait macules. So in a prepubescent, prepubertal child, I need 5 or more of these cafe au lait macules that are more than 1/2 centimeter in size. So a lot of times when I'm like, oh, there's a birthmark, oh, there's another one, totally fine. When I start counting and I'm like 1, 2, 3, 4, 5, 6, 7, 8, and each well visit there's more and more, that's when I start thinking, huh, well that's not normal. So that's why it's important to document those all the time. Again, the freckling. If you see hamartomas, it's probably not in a child, it's probably an older adult, but that is part of the diagnostic criteria. Your fibromas, so certainly if you see any of those cutaneous fibromas anywhere, if you ever have an optic glioma or these osseous lesions, this dysplasia, certainly that's one of them. But your other diagnostic criteria is if you have a parent, a first-degree relative, with neurofibromatosis. So this is not an uncommon scenario in pediatrics, where a child, let's say they come in for bronchiolitis, a viral URI, and you get them down to their diaper and you're starting to do a physical exam and you're like, 1, 2, 3, 4, 5, 6, 7, 8. Oh, there's several of these. And you say, hey mom, dad, has anyone ever heard of the diagnosis neurofibromatosis? And mom lifts her shirt and says, oh yeah, I have these. Well, now they came in for a viral URI and you've just met the 2 diagnostic criteria. So they leave with a diagnosis of NF1. Okay. So, very real thing that happens. So this is a criteria to be aware of when you start seeing those things that they're not even coming in for, but you're doing on your surveillance. So what are those complications? Is this just cosmetic, like good to know? Well, it depends on where those neurofibromas are. So they could be just on the skin and it's no big deal, or they could be along the nervous system anywhere, so it could be very variable. You could just have some cosmetic issues. You could have some specific neurofibromas in the brain that can cause things like seizures, learning difficulties, any kind of neurologic challenges like that. You can see them anywhere along that nervous system. So pick a place, any place, and you can see that. Neurology will thus then take a scan basically everywhere to say, where are the neurofibromas? Where would we need to be watching for this? And then ophthalmology to make sure there's no tumors of the eye, or if there are, that they're watching very closely for different visual problems with that. But wait, if there's a type 1, is there a type 2? And I can't believe you asked such a good question. There is, in fact, a type 2. So this one's also autosomal dominant. It's just a different chromosome. It's making some different things. Also a tumor suppressor gene, so this one just continues to make as well. You can tell that some pediatrician thought themselves very funny at some point, named this substance Merlin. We were just like, we thought we were wizards or something. We're just nerds at heart. But this one is a lot more sporadic, so there's not a family history in almost half of these cases, so much less likely that you're gonna walk in and a mom or dad just says, hey, look at my neurofibromas. Much less likely. What I need you to word associate, so what you need to highlight on this slide, if you ever hear a bilateral acoustic schwannoma, bilateral acoustic schwannoma, both sides, a tumor on that acoustic nerve or auditory nerve. That goes with neurofibromatosis too until otherwise told. That's the word association there. I've never seen that. That is one even that, gosh, if you see that, put those two together. This one is a little different. It doesn't have that freckles, doesn't have some of your cafe au lait as much, so it looks very different, and most of the time bilateral acoustic schwannoma. And really, the diagnostic criteria looks very different. This is for awareness only. So this is usually where I see it, and I did it again, where all of you guys are just like cross. Like immediately you're like, I don't want anything to do with that. That's fine. It's much more rare. What I want you to be able to just know is that two different diseases, even though they have similar names, they present very differently, and they have two sets of diagnostic criteria. Okay? So awareness only, that is a totally different set of diagnostic criteria, and what I need you to know is the criteria for NF1. Total switcheroo, next neurocutaneous syndrome that we're going to talk about is tuberous sclerosis. So this is another autosomal dominant. So how many parents have this? One or two, but one at least. Some of them, though, do have these sporadic cases in nature. These are, again, they're on their own, they're a benign tumor type. However, these ones can be so significant in their size and where they are specifically, and these ones can become malignant over time because they just get out of control. And it's a little bit more of a serious thing that we watch for tumor surveillance and tuberous sclerosis rather than NF1. A couple of different genes. Guess what TSC stands for? Tuberous sclerosis, exactly. So we have two different genes that make up for two different proteins. And something interesting to know, we don't really talk about it a whole lot, but there is a whole entity called infantile spasms that are a specific entity completely different from seizures. So this is not a seizure, but it's more like a myoclonic jerk that the child will do. Terrible, terrible prognosis. This can be one of the reasons why, because they have an underlying diagnosis of tuberous sclerosis. Where the tubers are will matter what this child looks like. So if you have completely benign tubers in a completely benign spot, and these tubers don't go crazy, and I am saying tubers, not tumors, even though they are a type of tumor, you are totally fine. If you have these tubers inside parts of the brain, you can have intractable seizures, significant intellectual disability. So the clinical presentation between patients can be vastly different for tuberous sclerosis. You might have patient one over here who functionally has a pretty normal life, and patient over here who has functionally a completely devastating set of symptoms that they have, refractory symptoms. So things that I need you to put together are tuberous sclerosis are going to have epilepsy, depending on where those tubers are, some form of intellectual disability, and then the facial features of that adenoma sedation that we'll talk about. So this is a tumor inside the vessels of the face, so a fibroangioma. So is what is happening with that those proteins. The tubers themselves end up pushing against the cerebral cortex of the brain. We'll take a look at that. That can lead to actually dysplasia of the brain. So the brain itself will remodel to kind of make room for those tubers, and that is what is causing some of your underlying intellectual disability and the epilepsy associated with this. The angiofibromas that I was just talking about, they will be on your face, and they will look very similar to the distribution of acne. So this would be a mimicker of acne, because you're looking at this very, very red, kind of papule in nature, but maybe you start seeing this in a 3 or 4-year-old. And so you think to yourself, ooh, this 3 or 4-year-old, acne, androgens, I know it, it's precocious puberty. And that's why you need to know all of those precocious puberty signs to say, well, wait a second, they don't have any signs of true puberty. What was the true puberty sign for females? Breastfeeding. Yep. What was the true puberty sign for males? Testicular enlargement. Perfect. So when you don't see that in children, have this really started puberty? No. So if they really haven't started puberty, is any of this on the face really androgen? No. It's something else. You have an acne mimicker. The other thing you'll see with this is an ash leaf spot. So if you are a millennial, I'm an elder millennial, much like some of you in this room, but we used to do these things where we would tan, we would like put a sticker, and then you would tan everywhere but the sticker. There's this like little white area. That's what an ash leaf spot looks like. It's a little area of hypopigmented, and it's often in the shape of like a leaf, right? So if you think about that, think about your millennial roots in there, that's what an ash leaf spot is going to look like. A shagreen patch is almost the exact opposite. It is an area that is raised and really rough. It's an area that has a plaque. It can be anywhere, but it's often seen on the back and the buttocks. So those are the things that we will see. So when you're on exam and you're like, this 4-year-old looks like they've been tanning like a millennial. It looks like they have acne, but they haven't started true puberty. And something with their developments and intellectual abilities not quite what I would expect it to be. How do I put all of those symptoms together? That's tuberous sclerosis. Something else to be aware of usually happens later in life, but you have these tubers and you get these renal angiomyolipomas, and they can become malignant in transformation. So that is usually one of the things that can be the cause of their demise later in life, so once you guys take over treatment. Something to be aware of. You're like, great, what am I looking at? Well, the top right is that ash leaf spot. So again, it looks like they just put a sticker right there and they're tan everywhere else except for that hypopigmented area. The shagreening patch is at the bottom. That's a picture of rough, raised plaque area. And then what you're looking at, I wish I had a pointer, right in the brain, if you're looking at the ventricles themselves, they look like they have those little spuds off of a potato, off of a tuber. Right? So you're seeing that poke into the cerebral cortex. So these tubers all over the brain. So that's what you start seeing those and you're like, how in the world do I put this together? Tuberous sclerosis. And it's all because it was embryological ectoderm. Another hypopigmented ash leaf spot. You see this is the middle picture of that adenoma sebaceum. So it looks kind of like a mimicker. And so on what the boards will typically do, one of your options will be acne. One of your options will be PCOS. One of your options will be lupus. And one of them will be tuberous sclerosis. Right? So that's typically your differential there. And so you're having to pick out which one of these is it. The other thing that just, if you see this ever, someday one person on this board is going to be like, oh yes, you said that. A rhabdomyosarcoma, you can see that in a cardiac. So a cardiac tumor is super, super rare in a kid. But if you see a cardiac tumor, it often goes with tuberous sclerosis. So that's what the echo down there is showing. And then the renal manifestations. So really pick an organ, any organ, you get some tubers there, you got some problems. More of them, tubers, adenoma sebaceum, kidney issues, hypopigmented. Trying to beat it into your brain. You know your brain is very, very full. Very, very tired of this. You're doing so great. So, so great. What I don't need you to do is not to memorize this either. Again, for awareness sake, again to say, even though they're all neurocutaneous, they're all autosomal dominant, they ultimately have very different manifestations and they each have their own diagnostic criteria. What I need you guys to do as primary care PAs is to say, I did a really good history, a really good physical exam, and that's different, that's abnormal, that's abnormal. How do I put these together? Because in kids, this is what I really need you to get. In kids, it's probably not 13 different little diagnoses like it is adults, where you're trying to plug holes on some ship. It's probably one unifying diagnosis in a child. much more likely that it is genetic in nature. So when you see all of those things, intellectual disability, a hypopigmented thing, adenomostivation, what? There's a unifying diagnosis for kids. So that's what I really want you to be able to take away from all these different criteria, is that ultimately there's these unifying diagnoses. Don't memorize those. So you're doing your physical exam, you will end up scanning them basically head to toe because you're looking all down that neurologic system. Where are the tubers? Where are they? Look at that. You will biopsy the skin lesion ultimately to make that DNA diagnosis, to be able to find that genetic reason. Neurology will always do supportive care. They will always do this seizure management and regular surveillance because they want to pick up to make sure, are we missing the tubers in the brain? Are we missing them on the spine? Are we missing them in the kidney? So a lot of surveillance to say what's happening next to anticipate with these kids. Depending on where and how many the tubers, your neurologic function is going to be your diagnostic marker. So how much dysfunction are you going to have over time? Again, something will usually become malignant over time, and that will be the reason that they succumb. Something very, 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 very variable, depending on what becomes malignant when, how bad they had it to start. Which takes us to Sturge-Weber, right? So what did we have? What was the inheritance pattern of muscular dystrophy? X-linked. What about NF2? Autosomal dominant. What about NF1? What about tuberous sclerosis? Autosomal dominant. Perfect. Sturge-Weber, it's not inherited. Every single one is a spontaneous mutation. Something went haywire after conception where all of these things are spontaneous in nature. What happens here is a very sad disease where the leptomeningeal blood vessels, and you're thinking leptomeningeals, what in the world is a leptomeningia, right? So meninges, the covering of the brain, the leptomeningeals are the two most inner ones. So between your pia mater and your arachnoid mater. So it's covering your entire brain, and all of these connecting blood vessels that supply the brain are not formed correctly. And so you end up with this manifestation really functionally of a brain that's having a really hard time, particularly on one side. And so it correlates then with an ipsilateral, which means if my brain was affected here, is the lesion on my left or my right? On my left, right? We don't see that a lot in neurology. This is an interesting one. You don't see a lot of ipsilateral issues. You see a lot of contralateral. So this one, leptomeningeal, is the issue. Ipsilateral port wine stain. Port wine is a very dark red wine. So these kids come out the womb, and you look like you just poured a Merlot on them. That's what their face looks like. You look like you did just this giant nevus flammeus there. The problem with this is that it's the blood vessels themselves that are formed incorrectly. And that becomes a big problem because everything is an increase in pressure. So if there's increased pressure in my brain, I'm going to short circuit. If I increase pressure in my eye, I end up with glaucoma. Okay? So because it is in that trigeminal nerve distribution, which cranial nerve is trigeminal nerve? 5, good. So your 5th cranial nerve is involved, and all the blood vessels in your eye are involved. We increase your pressure, and thus you're more likely to have glaucoma. So the glaucoma part is your seriously no miss. So you're going to be able to see on exam the port wine stain. You're going to know because this child is seizing in front of you, but the no miss is the glaucoma, is the eye. So seizures are intractable. In all of the cases of this I've ever seen, the seizure management is just absolutely horrific. And then because it is affecting the covering of the brain and the underlying parenchyma, you can see all kinds of things. So you can see that they can't feel part of the face or part of their body. You can see that they look like they almost have had a stroke. Intractable headaches, seizures, very, very bad learning disabilities, intellectual disability. So neurologically, these kids can potentially have a very, very hard time. So who are you going to refer them to? Well, neurology, absolutely. So look at this. If you look at this brain, you look at one side and you're like, one side's doing okay. The other side, not so much. Right? So that is going to be the side that has the problem, the side that looks like it is just shrunk up over time of being under a lot of that pressure. So 3 places that you're going to need to go. So neurology for the seizure management, the seizures that are intractable. Number 2, dermatology. Want to see if there can be some laser therapy for that nevus flammeus, but also for the cosmetic appearance. 3, ophthalmology, the no miss. They need to have that pressure of their eye and preserve that eyesight for these kiddos. Ultimately, these kids have a really hard time, and they end up with some pretty wild surgeries to help control some of the seizures. So something to think about. Make sure you know that those are the 3 places that these kids need to get to when you're referring. They're delightful kids, though. They're great. So you see them, you know, looks like it's bottom or low on a baby. So think about that. And that is CNS. Which means we are going to cards. You guys need a little stretcheroo?